tells you that there's no change. The patient comes in too early, or the patient tells you that there is some improvement. So the patient is on an SSRI, or the patient is on fluoxetine, which is an SSRI, and what do we do? Okay? So, the patient comes in on citalopram. They come in after 4 weeks, and they say, you know what, nothing is working. What do we do at the 4, I guess we don't need that. What do we do at 4 weeks of an SSRI? We change, exactly, we switch. What do we do at fluoxetine? Remember, this is 4 weeks, this is 6 weeks. What do we do if at 6 weeks on fluoxetine they come in and nothing? Same thing, you change. What if they come in at 2 weeks and they say it's not working? What do? You tell them to wait. What if they're on fluoxetine and they come in at 4 weeks and they tell you it's not working? What do you tell them? To wait. What if they come in at 4 weeks and tell you they're a little bit better? Then what do? You increase the dose. And what do if they come in at 6 weeks and tell you that they're a little bit better? Then you increase the dose. Does everyone understand this? Be very careful. Do not confuse fluoxetine with sertraline, with paroxetine, with anything. Fluoxetine is the one that stays in the system the longest. The maximum, you don't need doses for this test, so don't worry about doses. Okay? So any questions on this? So let's repeat this because I think some of you froze. So you want this line repeated? Okay, so you come in at 4 weeks and the patient is on the SSRI and they say, yeah, I'm a little bit better. What do? Raise the dose. They come in at 6 weeks on the fluoxetine. Yeah, I'm a little bit better. You increase the dose. Are we okay with this? When you have premenstrual syndrome, you're going to use 2 weeks off, 2 weeks on, and basically you use tiny little doses because all you need is a little bit of increase in serotonin and that's it. So when you're treating a premenstrual dysphoric disorder, then you don't wait on the medicine, so you don't have these side effects, because the side effects never get to develop. This is not for dysphoric disorder. This is for depression. How many times do you switch to different SSRI before you switch class? I mean, you might try a couple or 3. You don't need to try every single one. Is there a reason to use fluoxetine over another SSRI? No. That's just all personal choice. No change and some improvement. The patient comes in. You've had him 4 weeks on citalopram. They tell you, I don't feel any different. My mood is the same. My energy, I haven't gotten any better. At 4 weeks, you should see something. So you switch it. Does that make sense? Okay. So are we okay with this? All right, let's move on. Whoops, sorry. Let's now talk about The things not to do. Do not do SSRI and SSRI. Do not do SSRI and MAOI. Why? Because this will cause the serotonin syndrome. So what do you get in the serotonin syndrome? Well, you get autonomic changes, right? Confusion, myoclonus, flushing, etc. Oop, that's way too many words. So they'll probably tell you about a patient that was put on a medication, then something else happened. They get confused. They call you, it's a serotonin syndrome. How do we treat it? Just stop the medicine. And you may give cyproheptadine. Okay? Are we okay with the antidepressants? Autonomic changes, blood pressure. All right, let's go back to the class slides. Let's talk about ECT. ECT is still the best treatment for depression. It's not the most likely, it's not the most common, but it is the best. Do you wait some days before switching? No, what we do is we cross taper. When one goes up, the other one goes down. So it's used for depression. It's used for people that are suicidal. It's used for people that maybe the medicines could make them sicker. And it's used for people who it worked well on. So if your meds aren't working, if you're very suicidal, if the meds, if you can't be on meds, or if you had it before, then it would be perfect. Also, if you're pregnant, it's probably the safest thing to use. You're going to have some memory disturbance, and basically what you get is retrograde amnesia, but once the ECT stops, your memory comes back. The only relative contraindication, not absolute, relative contraindication is increased intracranial pressure. They're not sure how it works. They think that the shock raises the neurotransmitters. Okay, let's talk about the mood stabilizers. When we talk about bipolar disorders, let me get to the whiteboard 1 second. There's no absolute contraindication. None. So when we talk about bipolar disorder, you are either the manic type or you are the depressed type. If you are the manic type, what is recommended is lithium, valproic acid, and antipsychotics. If you are the depressed type, you can have lithium, and you can have lamotrigine. Tell me what drug appears twice. So what do you think the drug of choice for bipolar should always be? If you don't know the answer to it, what should you always put? Lithium. Oh, you know what? Something just popped into my head. Lorazepam is an atypical antipsychotic, and it's the only one that's in category B of medications. So this is the only one that would be the safest in pregnancy. I could see that appearing on the exam. Okay, so lorazepam would be the safest one for pregnancy. Good, we're set. Let's go back to the slides. All right, so let's review the side effects of lithium. Lithium is what you call a drug that has a narrow margin of safety. We use it for bipolar. We use it for stabilization of mood. What are the side effects? You're going to get a lot of tremors, a lot of GI side effects, headaches, weight gain, hypothyroidism. So what must we do? We got to check TSH. Polyuria, polydipsia, because patients get nephrogenic diabetes insipidus. It is teratogenic. It causes malformations in the tricuspid valve. Tricuspid valve, and the name of it is, you want to go to the lithium whiteboard? Hold on. That one? Okay. So lithium, before you start anybody on lithium, what should you always order? You want to order thyroid, right? You want to check TSH. You want to order pregnancy because it's teratogenic. And it's also nephrotoxic, so you want to make sure that you check kidney function. It can worsen acne, cause leukocytosis. It can have cardiac problems, so maybe you should get an EKG as well. The spelling of what? Oh, I'm sorry. It's in here. It's in the slides. We're going to see it. Lamotrigine is in here. If you look at page 92, it's there. You want to keep the level below 1.5 and probably closer to 1 as possible. Lithium takes about 1 week to work. Okay? It's a very good drug. So if you're clueless and they're asking you a bipolar question, pick lithium all the time. By depressed version of bipolar, do you mean hypomanic? No, I mean depressed. So what I mean is you are now here. And this one is right there. This is all bipolar disorder 1. There is bipolar 1 and 2, but it all depends where they are. You are not going to see this on your exam. All you're going to see is bipolar disorder. But when you look at the symptoms, then you decide, are these manic symptoms? This is what I give you. If it's depressive symptoms, this is what I give you. Does that make sense? Okay, let's go back to the slides. Hold on a second. Okay, let's turn here. Then we've got valproic acid, which is also used in bipolar disorder. It's also used for that person that's the rapid cycler. Remember, I went over that. That's the individual that had at least 4 or more episodes in a year. So the rapid cycler would be 1, 2, 3, 4, if this is 1 year period. So you have 1, 2, 3, 4. That's a rapid cycler. It's similar to lithium, except it causes sedation, cognitive impairment. It's hepatotoxic, so you want to check LFTs. It's also teratogenic, so you want to check pregnancy. And it also causes alopecia. It also causes a lot of tremors. Carbamazepine is also used. Carbamazepine can cause agranulocytosis. So you got to be careful with that as well. And then you've got lamotrigine, and lamotrigine is in there. Lamotrigine, all you ever need to know is that it's Stevens-Johnson syndrome. That's it. And the Stevens-Johnson syndrome is a rash where basically your skin falls off and you can die. So let's talk about bipolar disorder and how to treat it. What kind of questions can you expect on bipolar disorder? They could give you bipolar disorder and something else. And then they could give you lithium as a choice, and they could give you valproic acid. If this is a bipolar patient who has cirrhosis, then what would be better? If you're bipolar and you have cirrhosis, then you pick what do you think you pick? Do you pick A or do you pick B? You pick A. Why? Because we know that valproic will affect the liver. What if you're bipolar and you've got renal disease? Do you pick A or do you pick B? Then you pick B. Okay? Does everyone agree? All right. Now, when they give you bipolar disorder and something else, and they make you choose between lithium, valproic acid, and an antipsychotic, what do you think that something else is? Remember, lithium takes about a week to work. Valproic takes about a week to work. The antipsychotics work immediately, right? Everyone agree? So typically what they're going to give you here is acute mania. I mean, that person is totally out of control. So what's going to happen is that you can't wait for the medications to work. The patient is jumping in the ER, assaulting someone, talking really fast, totally out of control. Then you give them the antipsychotic. The question will only be the antipsychotic. That's type 1, yes. This is what the question looks like, okay? So give me a minute because I'm going to type it for you. So you've got a 25-year-old female diagnosed with bipolar disorder and on lithium 900 milligrams. She is taken to the ER by the police after neighbors complain. She is loud, has pressured speech, racing thoughts, and just hit a nurse on the face. What is your next step? Blah, blah, blah. Do you A, check lithium level? Do you B, increase lithium? Do you C, add valproic acid? Do you D, admit to psych? Or do you E, give olanzapine? Okay, here's your choices. Exactly. E is the correct. This is not the correct answer. What do you think her level is? 0. When would A be correct? Here, let me give you an example. 65-year-old female on lithium for 35 years. She is on lithium 900 milligrams a day. She has had a cold for the last few days and has not been eating or drinking fluids. Today she appears confused and is taken to the hospital. What is the next step? Okay, and we're going to use the same choices. Remember, what happens to the GFR in the elderly? It goes down. The elderly might need lower doses. So now level is checked. Why? Because now we suspect toxicity. Excellent. So do you see the differences? Good. All right. Let's go back to the slides, and I think we're going to finish this section. And then let's just talk about the anxiety. When would D be correct? What was D? Admit. You only admit after the patient is stable. You don't admit if they're totally out of control. You got to stabilize them first. Now, when we talk about anti-anxiety meds, you know that there's two types. We've got either the benzos, and we've got buspirone. Get rid of this. So the benzos, how do they work? They open up the chloride ion channels. They facilitate the transmission of GABA. Remember, GABA is the major inhibitory neurotransmitter in the brain. Remember the OTL. Remember that they're addicting. They could be abused. They can cause memory problems and falls. Because they work immediately. Buspirone, they believe, works on serotonin. They are for anxiety, but buspirone is not addicting. Buspirone does not potentiate alcohol. Buspirone does not have withdrawal. So if you have a patient who has anxiety and is an alcoholic, do you give them A, lorazepam, or do you give them B, buspirone? What do you think? What do we worry about? You drink on a benzo, you're going to die. So that's when buspirone is the better answer. And it is approved for generalized anxiety disorder. And we're done with the meds. Are you okay with the medications? All right, so let's stop here. Let's stop here and we'll break. And then when we come back, we'll do the next chapter, which will be on sleep. All right. I think one of you was asking me about NMS, serotonin syndrome, and hypertension crises. So is this okay? All right. So let's go on to the next chapter, which is the chapter on sleep. And they do ask sleep, you know that. So let's get some color out here. Do you have class tomorrow? Good. I'll put that slide back up in case some of you want it. So at the next break, I'll put the slide back, okay? All right. So sleep, you know, how many REMs do we need in learning process before exam? Oh gosh, I wish I knew. You just need REM. So sleep, you know, will come out on the exam. So basically, what we have to understand, I'm going to call it a moderate yield. So I would expect something on sleep. I don't expect tons on sleep. Will it be there? Yes. So will you see a lot of questions? Probably not. But it will be there. That I can assure you. So sleep is divided into two stages. Hold on, let me see it. Oh, sorry. So you've got REM and you've got non-REM. And non-REM is divided in 4 stages, which are stage 1, 2, 3, and 4. Stages 3 and 4 is where delta sleep occurs. And that's why stages 3 and 4 are also called delta sleep. Delta is a very slow wave, and that's why stages 3 and 4 are also called slow wave sleep. So stage 3 and 4 has been called slow wave, has been called delta. REM and non-REM are almost like polar opposites. So let's review that. So what happens in non-REM? You have no eye movements, because where do you have eye movements? In REM, as your eyes are flickering back and forth. In non-REM, you have a very slow EEG because your brain is not really active. But in REM, your brain is very active because that's where you're dreaming. In non-REM, you have a lot of muscle tone, so you're moving around, whereas in REM, you don't have any muscle tone. So basically, non-REM, the brain is inactive, but the body is active. Stage 1 is where we have the theta wave. Stage 2 is where we have K complexes and sleep spindles. Stage 3 is delta, and stage 4 is delta. That's why 3 and 4 are also called delta sleep. Notice how stage 2 is the longest of all the sleep stages, anywhere between 6 to 8 hours a night sleeping. Some of you are here, some of you are here, some of you are here, and some of you are here. So you're either a sleeper, right? Or you are a non-sleeper. That's basically how we categorize ourselves. So if you sleep 8 hours a night, almost half of that is going to be spent in stage 2. So stage 2 is the longest of all the sleep stages. REM, you're going to have active EEGs because that's where you are dreaming. In REM, you're going to have penile erections, and that's why we test men during REM. In REM, your eyes are moving back and forth, and that's called a saccadic eye movement. And in REM, your body doesn't move. So REM basically is a brain that is active, but a body that is inactive. Make sense? How many of you are sleepers out there? Where's a shout out for the sleepers? Okay, where are the non-sleepers? I'm a non-sleeper. And I don't understand you. Don't understand why the sun's up, you should be up too. Okay. Then we've got REM. REM, what we have is sawtooth wave, and this is the second largest. So when we divide the night in two, we're going to find more non-REM in the first half of the night and more REM in the second half of the night. Okay? So this is just a review of everything that we've done. Stage 2 is the longest, is the deepest. So because it's deepest, it's very hard to wake up. This is what you call the restorative part of sleep. You need this so that you're not tired. You need this sort of like to get energized. So the elderly tend to have less of it. So what is one common complaint that the elderly always have? What do they always complain about? That they're tired, right? Why should they be tired? Because they don't have as much. 3-4. REM is a very easy stage to wake up from, and it tends to lengthen over time. So what does that mean? The first REM of the night is like 10 to 15 minutes. The last REM of the night is like 20 to 40 minutes. So remember, there's more REM in the second half and more non-REM in the first half. In the second half, you're either in stage 2 or you're in REM. And then that depends on whether you remember your dreams or not. If you wake up out of REM, you remember your dreams. If you wake up out of 2, then you don't remember your dreams. Here's normal sleep stages. We read this from left to right. These are the hours of sleep. This is the depth of sleep. So how do we read this? This right here is what's called sleep latency. Sleep latency. That's from the moment you go to bed to the moment you wake up, and it's an average about 5 to 15 minutes. So when you're tired, what happens to sleep latency? Does it go up or does it go down? It goes down. When you have insomnia, what happens? It goes up. So the way that you go to bed, you fall asleep, you go to stage 1, 2, delta, 2. Here we have the first REM of the night. From the moment you fall asleep to the first REM period, that's called REM latency, and that's about 90 minutes. You then go back to 2, delta, 2, delta, 2, delta, REM. You woke up for a little bit, you covered yourself with a blanket, and you went back to sleep. 1, 2. Wherever you see a shaded area, that's a REM. Wherever you see a non-shaded area, that's a stage 1. And you just go throughout these stages as the night progresses. So REM latency is about 90 minutes. So if I draw the line down, there it is. If I divide the night in 2, where do we have more REM? We have more REM here. Where do we have more non-REM? Here. Okay? Are we okay with that? All right. Are they going to ask you waves probably for stage 2? No. So here you have a theta wave, which is what you find in stage 1. Stage 2, you've got sleep spindles and K complexes. And stages 3 and 4, you have delta, which is a very slow and a very wide wave. So we talked about REM latency, we talked about sleep latency. Now, what happens to us as we get older? Everything goes down, right? So let's talk about total sleep time. So here we have the age from left to right, and these are the hours of sleep. So as you can see, a baby can sleep up to 16 hours a night. Toddlers and adolescents can sleep more than 8 hours, and adults, and the older we get, so an elderly person can sleep maybe 6, 7 hours. So what happens to total sleep time? It goes down. Let's talk about REM, the area in green. A baby is 50%, adolescents, adults 25%, elderly 20%. So again, REM goes down, and non-REM tends to decrease in the elderly. So you see this, so you have less non-REM. The neurotransmitters of sleep, you're going to remember the mnemonic, the Sandman. The Sandman is the one that brings you your dreams. So S is for serotonin, A is for norepi, and D is for dopamine. So anything that raises serotonin, what's it going to do? It's going to help you sleep. Anything that raises acetylcholine is going to produce REM. Anything that lowers norepi is going to produce REM, and anything that raises dopamine is going to cause arousal. So understanding how these neurotransmitters work, then we can play with drugs and determine what happens where. So what happens when you take tryptophan? Tryptophan, remember, is a precursor of serotonin. So we find tryptophan in milk, we find tryptophan in turkey. So tonight, you have a glass of milk and a turkey sandwich. Should you sleep better or not? You should fall asleep and sleep better. Good. What if I give you haloperidol? You come to my house, and I put haloperidol in your drink. What do you think is going to happen? Haloperidol is a dopamine antagonist. So do you sleep more or do you sleep less? More. Why? Because you don't have, do you sleep more or less? More, because you don't have the arousal, right? Okay. What if you come back the next day and I give you bromocriptine? Bromocriptine is a dopamine agonist, so you're going to sleep less. Less. Why? Because dopamine goes up. Now you understand why people never want to visit me. Benzos suppress stage 4, and if you use them chronically and you stop it, then you get an increase in sleep latency. Alcohol and barbiturate intoxication both suppress REM, but alcohol and barbiturate withdrawal will have REM. Yes, dopamine, when you're ready to wake up, towards the end of the cycle is when dopamine goes up. What exactly is REM rebound? When you don't allow REM to be and you suppress it, it comes back with a vengeance. So you have more of it. So what happens in major depression? You're shorten REM latency. So instead of 90 minutes, it's about 60 minutes. REM time is higher, bigger. You suppress delta. Multiple awakenings and early morning awakenings. So you're going to have a lot of waking ups in the sleep architecture. Okay, let's talk about the disorders, because that's really what comes out on step 2. A 35-year-old man was recently hospitalized for the 10th time after he crashed his car into a post. When questioned, he did not remember the cause of the accident and just had his license suspended. His friends reported occasions when he fell asleep during dinner and during conversations with them. What is REM rebound? Give me a second. let me go over this. When we have sleep deprivation, and we have lost sleep, right? So in sleep deprivation, you lose sleep. Everyone agree? Okay. So what happens when you do sleep? Well, we have an increase in total sleep time. We have an increase in 3-4, and we have an increase in REM. Why? Because REM was not allowed to be there. So whenever you hear the word rebound, it means you have more of it. So REM is important. Why is REM important? Because this is where we learn. Why is 3-4 important? Because this is the restorative part of sleep. So because these things are so important, it has to catch up when you do get to sleep. So where REM wasn't there, when you sleep, then you're going to spend more time in REM. Does that make sense to everybody? All right, good. So we have a person who crashed his car, and hold on, let me get some colors out here. He crashed, didn't remember the accident, he had his license suspended, and then we learn that he falls asleep during dinner and talking to friends. That's what narcolepsy is. So narcolepsy is a disorder of REM. So you're in REM in less than 10 minutes. So these are people that are just falling asleep everywhere, while driving, while talking, while working. A clue for this is that when you wake up, you're feeling very, very refreshed. And it makes sense. Why wouldn't you be refreshed? Because you just took a nap. So there are 4 things associated with narcolepsy. It's a tetrad. It's a tetrad of symptoms, where you have sleep attacks, which is the most common. You see this in about 80% of the patients. You ought to have cataplexy, which is pathognomonic. Cataplexy is a sudden loss of muscle tone, but you have not lost consciousness. That's important. So typically what happens, you're awake, and remember, cataplexy is the beginning of REM. How is the body in REM? Active or inactive? Off. So you go boom, and you fall asleep shortly thereafter. You're going to have hallucinations, whether they're hypnagogic or hypnopumpic. Gogic is as you're going to sleep. Pumpic is when you're waking up from sleep. But what's more common in narcolepsy is hypnagogic hallucinations. And the last thing that you experience is going to be sleep paralysis. So when you wake up in the morning, you really will not be able to move. And those are the 4 things associated with narcolepsy. So how on earth do we treat narcolepsy? Well, you can have the patient sleep, but how realistic is that? We want a medication. So when we're looking at the treatment for narcolepsy, we're going to go to 2 types of drugs. Give me a minute, because I'm good. Give me a sec, because I'm going to use the text box here. We're either going to use a stimulant, or we're going to use the non-stimulant. Now, when you compare the stimulant and the non-stimulant is called the non-stimulant because even though it works like a stimulant, it doesn't have the same side effect profile. What kind of side effects can stimulants give you? Well, you don't sleep, it affects your appetite, you can have anxiety, it raises your blood pressure. So the non-stimulant tends to do it less. So when you're looking at safety, not at efficacy, when we're looking at safety, which one do you think would be the better choice for patients who have this disorder? You would rather give them, and remember the addiction potential. So that's why the non-stimulant is the preferred. So modafinil is a non-stimulant. Methylphenidate or dextroamphetamine would be the stimulant. So when given the choice between stimulant and non-stimulant on the test, always pick the non-stimulant. Make sense? Does everyone understand that? Okay. If they ever ask about cataplexy, then a TCA or possibly an SSRI is used. Why? Because these two can affect REM. So by affecting REM, which is where they think cataplexy occurs, what do you think would be the treatment? Giving them this. But if they ever make you choose between an SSRI and a non-stimulant, what do you think is the better answer? The non-stimulant. Modafinil is the non-stimulant, correct? Modafinil is the non-stimulant. So are we okay with the treatment? Okay. Let's talk about something else. What they're doing with this disorder is that they're confusing you. Go on the text. So we've got the treatment for cataplexy can be an antidepressant or an SSRI, and believe it or not, GHB has also been used. They've used GHB, which is the date rape drug. It's being used for cataplexy. You take it at night, you get a full night's sleep, and they think cataplexy. But I cannot imagine that GHB would be the answer on the exam. Typically, for modafinil is the answer. Okay, so what happens here? You leave a bar, you crash, fell asleep, police notice, alcohol on your breath. You license. You also fall. Hold on, I gotta fix this. Alcohol on your breath. And you fall asleep. Is that A, narcolepsy, or B, alcohol use disorder? I mean, what they're using now for cataplexy is GHB. So here, what you think of is, well, what's happening with this person is that this person is an alcoholic, but we know they're not an It's very simple. The question they're going to give you is sorry. Then we have sleep apnea. Hold on, let me get my color out here. An overweight man reports having difficulty in his marriage because of his snoring at night. During the day, he reports feeling tired. So what we have here is a patient who has sleep apnea. Apnea is cessation of breathing for more than 10 seconds. So many of these patients can die from this because you can have pulmonary hypertension, you can have arrhythmias, asystoles, and death. So what's unique about the patient who has sleep apnea is that they're going to have a very loud snore. So when they give you sleep apnea, you usually see it more in obese, middle-aged men. So the sleep apnea questions come in two types. You either are the snorer, right? or you are the victim of the snorer. So what kind of questions do they give you? What are the words? What does the snorer complain of? The snorer complains of being tired. Why? Because they never enter the deeper stages of sleep. So if you don't enter the deeper stages of sleep, remember, that's the part that restores you. What should you complain of during the day? Feeling tired. Because you sleep with your mouth open, you also complain of a dry mouth, and you also complain of frequent headaches. Well, what does the victim complain of? Or restlessness. Why are you restless? Because you're trying to find a position which is easier for you to sleep. So these are the two things that they will give you as clues for patients who have sleep apnea. Does this make sense to everybody? So we talked about this. There are 3 types of sleep apnea: obstructive, central, and mixed. Of course, obstructive is the most common. The treatment of sleep apnea is to treat the underlying condition. Obesity, then diet. If it's because of something, maybe nasal obstruction, then surgery. But the best treatment is going to be CPAP, continuous positive airway pressure. So you're sleeping with this machine, you put a mask on your face. What the machine does is that it keeps your airways open. So by keeping your airways open, you enter the deeper stages of sleep, you get rest, and you don't complain of being tired. Another thing that you could do is that you'll see that in the back of their t-shirts, this is the back, they're going to sew a tennis ball. Now, why would they put a tennis ball? Because if you have a ball on your back and you're lying down, you're probably going to be uncomfortable. So you normally or unconsciously are going to turn to your side where breathing tends to be better. Yes, it's the body fat that compresses the airways. Correct. I cannot imagine that they would make you choose between CPAP and tennis ball. I think CPAP is definitely the better answer. Okay? All right. Do they really do this in practice? Oh, yeah. Nobody likes the CPAP. It's noisy. They complain of the mask. Then we have insomnia, which is a disorder of either initiating or maintaining sleep. And when you have a patient talk to you about insomnia, the first thing you need to ask them is, what in the world do you mean by insomnia? Because insomnia for them might not be insomnia for you. So I had a patient once tell me he would wake up every day at 4 a.m., which for all of us is insomnia. When I asked him what time he went to bed, he told me 7 p.m. That's not insomnia. So make sure that you and the patient are on the same page. There's lots of reasons why people have insomnia. If we're looking at insomnia because of psychiatric reasons, then depression and anxiety are the most common ones. And because depression and anxiety are more seen in women, then we know that women have it more than men if it's due to psychiatric reasons. Okay? All right. So when we're dealing with insomnia, how do we know when patients have insomnia? Because they're tired. They eat a lot. They yawn. They complain. Probably a lot of us are doing that right now. So how do we treat it? The first type of treatment is you want to discuss sleep hygiene techniques with the patient. What is that? Make sure they go to bed at the same time. Make sure they wake up at the same time. Don't sleep during the day. No caffeine. No alcoholic beverages. Don't eat heavy meals before you go to bed. Make sure the room is comfortable. Make sure the bed is comfortable. The temperature is comfortable. All of these things that you try to fix. If it doesn't work, then you could try behavioral modification, which is a technique called stimulus control, where basically, how many of you have insomnia every once in a while? How many of you out there have trouble sleeping? I do sometimes. So like when I teach, I can't go to sleep. It's like 2 o'clock in the morning and I'm still tossing and turning. I guess I'm kind of wired, so I don't sleep well. So for those of you that don't sleep, how many of you watch TV? How many of you read? How many of you text? How many of you Facebook? How many of you talk on the phone? How many of you are in a love affair with your iPad or tablet? Or how many of you play Candy Crush before you go to bed? So what does this tell your brain? Your brain's a mess. This woman who comes to bed tonight, what is she going to do? Is she going to watch Scandal? Is she going to read something that some crazy thing she finds in Google? Is she going to text her friends? Is she going to Facebook to see what's going on? Is she going to talk on the phone? Is she going to play Candy Crush? Or is she going to do who knows what on her iPad? So my brain is all confused. So what you need to do is tell the brain, no more of this stuff. Nothing. And you only use the bed for sleeping. And when you do that, then you'll eventually fall asleep. Okay? Make sense? Now, if we do treat patients with medications, which remember are the last resort, let's go over meds for a little bit. When we talk about meds, and let me use the text, let's talk about the history of sleep medications. Trazodone is used for sleep. Diphenhydramine, which is Benadryl, is used for sleep. Tricyclics are used to sleep. And benzos are used for sleep. But what's the problem with those drugs? Patients would complain of feeling groggy or having a hangover feeling, right? They didn't like it. You wake up in the morning and your head is going, rah, rah, rah. So patients didn't like these types of drugs. So then the pharmaceutical companies came around and created a group of benzos that specifically targeted the sleep receptors. Those were triazolam and temazepam. These benzos took off like wildfire. Everyone and their mother was on it. But what happened? Abuse, falls, memory, confusion. That was bad, right? Well, then the pharmaceuticals created another type of drugs, which are sort of benzo-like, but they're not technically benzos. And those are zolpidem, azopiclone, and zaleplon. Those are the newer medications, but what's the problem? They are still addictive. If you've ever seen the commercials for Ambien or for Lunesta, notice how the commercial goes on, and then at the very end, they mention use of this medication may be addicting. When a pharmaceutical company says that a drug may be addicting, what does that mean in the real world? It is, right? How do these drugs work? Well, all of these drugs work basically by reducing sleep latency. So what happens? I take a pill and I fall asleep quickly. I take a pill, I fall asleep quickly. I take a pill, I fall asleep quickly. What happens the day I don't take the pill? What happens to my sleep latency? It goes up. So do you think that perpetuates the addiction or not? You're going to go and take the pill again, right? Exactly. Now there's another drug which works differently. Then there's another drug which is called, hold on, Ramelteon, and it works on melatonin. So Ramelteon is not addicting. So what kind of question could they ask? All the Z-Quills and the Advil PMs and all of that are in this class here. Because what a lot of them have is that they have a Benadryl attached to it, so it causes sedation. So if they're asking you for insomnia, what's the best treatment? You always say sleep hygiene. If they're making you pick a drug, you pick one of these. They won't give you two of them. You pick one and you move on. But if they make you pick between Zolpidem and Ramelteon, and it's a person who has insomnia and is an addict, what do you think is the better drug? I'm not necessarily talking about physical, I'm talking about the psychological addiction, that I take a drug and it helps me. So that's the hardest part to get rid of. So does everyone, so these are sleep disorders related to the sleep cycle. So this is what we need to remember. What's the difference between a nightmare and a night terror? Here it is. Nightmares, everyone can have nightmares. Where do nightmares occur? In REM. Can you remember them? Yes. Night terrors occur more frequently in children, and they occur in 3-4. And do we remember them? No. That's it. So a nightmare is a bad dream. It occurs in REM, and we can remember. A night terror is a kid screaming in the middle of the night. Bah! My voice is hoarse. I can't even talk anymore. Bah! Goes back to sleep. You wake up in the morning and you ask the kid, what happened? The kid's going to look at you like, what are you talking about? Nothing. I have such a raspy voice now. And do you believe I don't even smoke? Do you imagine if I did? Okay. Sleep talking, I put it in there because everyone always wanted to know. Sleep talking is also called, let me give you the official name. Let me go in the text here. Sleep talking is called somniloquy. Yes, I have allergies and asthma. So sleep talking, somniloquy, occurs in all sleep stages. You can either say a word, you can say full sentences, and unfortunately, for those of you that do it, no treatment. So be careful what you say. Sleepwalking, the technical name is, hold on, somnambulism. And I think I spelled it wrong. So somnambulism is that person that goes to sleep in their own bed, then they wake up in the middle of the night, they walk around the house, they clean, they cook, they end up in some other part of the house. If you wake them up, they're confused, they're disoriented, and it basically occurs in stages 3 and 4. And I think we are done with this chapter. Any questions on sleep? All right, so let's go on a break here, and I'll see you in 10.